Hello, this is Eric Thompson, and today I will be discussing thalamic tumors. The objectives of this presentation will be first to discuss the different types of thalamic tumors, second to discuss pertinent anatomy, third to discuss the surgical decision making, and fourth to describe operative approaches. The far and away the most common types of tumors in the thalamus are gliomas. Most of these tumors are low grade, just over 50%, and these consist of pilocytic astrocytomas and diffuse astrocytomas. Just under half of the gliomas are high-grade gliomas, and a significant portion of these are what are now considered malignant midline gliomas, and these are discussed more in the text of the chapter itself. And third, very uncommon but occasionally seen are other types of non-gliomas such as gangliogliomas, embryonal tumors, and ependymomas. Next, we'll discuss relevant anatomy. So this is a figure from an article by Rebus et al. In JNS in 2018, and it gives a nice overview of the venous drainage of the thalamus. So the most important structures relating to the venous drainage include the anterior septal vein here, the thalamostriate vein here, which is really the part of the anterior border of the thalamus, and very important is the internal cerebral vein located medially. So when we approach these tumors surgically, it's important to try to maintain the patency of these venous structures to avoid deep infarcts. So next, to discuss the arterial anatomy, this is a figure taken from Hal Blumenfeld's book from 2010. The thalamus here is highlighted in red, and very important arteries supplying the thalamus include the posterior choroidal artery, the thalamo-geniculate arteries, and the thalamoperforator arteries. Also making an important contribution is the anterior choroidal artery. So in review, the ICA supplies the anterior choroidal artery, which supplies the anterior and sometimes medial portion of the thalamus. The PCOM and basilar artery supply thalamoperforators, and the PCA supplies the thalamo-geniculate and posterior choroidal arteries. Next, we'll talk about surgical decision making. This is a simple flow diagram that we use to determine the best course of treatment for patients with thalamic tumors. So first, we'll discuss the diagnosis and treatment of a thalamic tumor without obstructive hydrocephalus. The first thing we must decide is whether or not we think a resection is feasible. And there are a lot of different variables that come into play here, including what does the lesion look like on MRI? Does it have well-defined borders, or are the borders very infiltrative? Is the lesion, can it be approached via non-eloquent corridor, and various other characteristics. If a lesion is deemed not to be surgically resectable, then we would certainly advocate for a stereotactic needle biopsy. If it is surgically resectable, then we would proceed with that. Regardless, we would then base our adjuvant therapy paradigm on the WHO grade and the histologic characters of the tumor, as well as now more and more frequently molecular characteristics of the tumor. So if it is a low-grade tumor and it's not quickly progressing, then oftentimes we observe these with MRIs. If it is a high-grade lesion, then these patients typically need radiation and chemotherapy. Next is a flow diagram of a patient that presents with obstructive hydrocephalus. So first and most importantly is to treat the patient's obstructive hydrocephalus. If they present in extremis, the most important thing to do is to urgently place an external ventricular drain to relieve the intracranial pressure. And then you have a little bit of time to decide whether or not a biopsy is more reasonable versus a resection is more feasible. If a biopsy is felt to be the best course of action, oftentimes this can be combined endoscopically with an endoscopic third ventriculostomy if the anatomy is favorable to perform this type of procedure. The other differentiation between this and the non-obstructive hydrocephalus patient is dealing with hydrocephalus if the ETV is not feasible or if hydrocephalus is persistent after a ETV, and then a shunt is likely necessary. And finally, adjuvant therapy, similar to those without obstructive hydrocephalus, is based on the WHO grade, the molecular and histopathologic characteristics. So next are some MRI examples of patients that may benefit from a biopsy versus those that may be best served with a surgical resection. So this is an example of a patient that has a left thalamic tumor. It's fairly well circumscribed here. There's even a cystic component laterally here that may make an approach either through a transcortical parieto-occipital or perhaps a posterior interhemispheric transcallosal approach reasonable. The next is another one that may be considered for resection. All this one looks like it may have more high-grade type features. It is still relatively well circumscribed and actually comes to the ventricle's surface. So even an approach through the ventricle here may be the best corridor to minimize damage of eloquent tissues in the operative corridor. This is another example of a very well circumscribed lesion that is likely amenable to resection via either a transcortical parieto-occipital approach or a posterior interhemispheric transcallosal approach. I would note that oftentimes the best way to approach these is to injure the tumor itself and using Cavitron to internally debulk the tumor before trying to define any sort of planes on the periphery which may not exist. This is another example of a very well circumscribed lesion that comes to the surface approaching the ventricle. So this lesion would likely best be served via a transcortical parieto-occipital approach through the ventricle or a posterior interhemispheric transcallosal approach. Now this is one that we would consider probably non-resectable. So it's really centered right in the middle of the thalamus. There's not really good edges. It's not well defined. And so this is one we would most likely perform just a biopsy on. This is an example of a very large tumor with poorly defined edges that has a lot of malignant features to it that also presents with obstructive hydrocephalus, as you can see with the transependymal flow. So the key here is treating the obstructive hydrocephalus. Some may consider debulking this lesion. However, if this is a high-grade lesion, simply debulking this may reduce some of the mass effect, but does not necessarily clearly portend an improved prognosis for this patient. And again, this is one that is totally ill-defined, that a resection would not be amenable without seriously neurologically harming this patient. This is an example of a biothalamic glioma, which we can see not infrequently. Obviously, surgery for resection is not going to be reasonable here, so a stereotactic biopsy is the best course. Next, we will be discussing operative approaches. This is by no means an exhaustive list of the approaches that can be used to the thalamus. These are just 4 of the more commonly used approaches. Also, I wanted to note that I do advocate using stereotaxy for these approaches, particularly the midline approaches, to avoid venous lakes and large venous structures. And it's also reasonable to consider using neuromonitoring with these thalamic tumor resections, including SSEPs and MEPs. So the first approach I will discuss is the anterior interhemispheric transcallosal approach, which is the workhorse for thalamic tumors. This is typically utilized for anterior and medially based lesions. It can be completed either via the contralateral or ipsilateral side, depending on really the best angle of approach. Also, it can be extended to include a transforaminal or transchoroidal approach if the tumor has significant extension into the third ventricle. It's really important for these approaches to avoid injury to the forniceal columns. The next approach is the posterior interhemispheric transcallosal approach. This approach is typically used for lesions that are posterior and medially based. Again, similar to the anterior interhemispheric transcallosal approach, it can be completed either via a contralateral or an ipsilateral approach to best optimize your angle of attack. Next is the transcortical parietal occipital approach. This is typically used for more larger posterior lateral based lesions. So it's important to tailor your corticectomy here to really try to avoid the optic radiations and posterior enough to really avoid Wernicke's area. Occasionally DTI preoperatively can be helpful here to avoid the optic radiations, to avoid a visual field cut as well. And it's also important to remember that because this is a transcortical approach, that the risks of postoperative seizure are higher than through the transcallosal midline approaches. Fourth is the supracerebellar infratentorial approach. This is typically used for posterior and inferiorly based lesions that approach the free edge of the tentorium. This is typically completed either in a sitting position or a park bench type position to really decrease the amount of cerebellar retraction needed to reach the posterior thalamus. So just a few notes on the postoperative course of these patients. It really completely depends on their resection or if they've had a biopsy. For patients that have had a resection, typically they will have a drain in place in the ventricle to drain blood products or debris temporarily. They will need intensive care unit care. If they've had a stereotactic transcortical needle biopsy, oftentimes they can be discharged the next day. We do strongly advocate discussion at a multidisciplinary brain tumor board regarding their adjuvant therapy. Regarding MRI follow-up, if they have had a resection, we do advocate an MRI within 48 hours, and then depending on their pathology at 3, 6, and 12 months. Thank you very much.